Okay, we're going to go ahead and get started, and I'm going to just go through a quick scenario on what is the problem with full-thickness cartilage defects in the athlete. So we got, and this is for Albert Gee. Tomorrow, I want you to watch this. Albert is the team physician for the Huskies. He's in the audience. He's going to talk a little bit. So this is a great tradition. Now, they try to emulate this at some other places, and they don't quite know how to handle a pony at SMU. Not quite like we can do the buffalo. Just to remind you of the difference. And I think you have a husky or something like that, Albert, up in that place in Washington. Just a big difference. So this is what we're looking forward to tomorrow. And Albert, wherever you are, just get ready for that buffalo so they don't run over your team as it comes out. So articular cartilage function, it distributes the load, it minimizes the stresses, and has a low friction surface. There's a lot of characteristics of it that are very important. It is avascular, aneural, has a low metabolic activity, and really an unimpressive appearance. It is a very interesting issue, but what happens when we have an injury to the cartilage in an athlete? So there's an acute injury, or sometimes these subacute, or these gradual mechanical overloads. What happens next if that injury happens in the athlete? Well, we know that articular cartilage does not heal. We know that even these partial thickness lesions do not heal. The full thickness lesions don't heal. The natural history of this is that you're going to develop joint space narrowing. At least 50% of the athletes that have a large defect and not even a full thickness will have a full thickness defect eventually. So what happens next with this injury to the cartilage? What about symptoms? Symptom variability. Certainly they're going to have pain, catching, swelling, giving way. And depending on how big a lesion will often dictate how their symptoms are. So what about athletic participation with cartilage injuries? The larger grade 3 and grade 4 defects are not well tolerated, particularly in the high impact activities. The grade 1 and 2 are tolerated, but there is a potential for an increase in size of these with the size and the severity of the defect. So what about the options? And this is what we're going to go next to with Dr. Podar. We're going to look at anti-inflammatories, glucosamine, viscosupplementation. These are ways to maybe manage that athlete in the season, but after the season, we may have to look more definitive treatment, arthroscopy, or if there is a big severe cartilage defect, do we have the athlete retire? Do we have other options? Do they look at different things for the rest of their life in terms of activity, biking, lower impact activities? The question is, can current cartilage surgical techniques give the athlete a chance? And certainly we have to look at that and look at the lesions and look at the different options, because there's a lot of different ways to look at this, and there's different options that there are. There's arthroscopic debridement. There's microfracture. There's different options such as osteochondral autografts that may restore the surface, but how durable are they? Looking at osteochondral allografts, and then even other options that may be available for the athlete. So we have to look at all these things. We have to consider these and look at comorbidities and look at things such as alignment. Look at the bow-legged person, and are we really doing them a favor by treating the cartilage? Maybe we need to look at other options that Dr. Vidal is going to talk about with osteotomies.